Welcome back to another episode of EM Board Bombs. This is part 2 of our critical care series that we are doing with our favorite critical care doctor, Haney. Haney and Blake did part 1. They're going to continue here with part 2. They are dropping key critical care pearls for the emergency room. This episode has been getting tons of buzz on the socials, Insta, TikTok. So here's the full length second part of that episode. As always, remember EM Rapid Bombs. EM Rapid Bombs is our premium podcast for board review, quick EM hitting pearls, 3 to 5 minute long episodes. We have more than 500 of those episodes now. They're in question and answer format. So if you're studying for boards, studying for ITE, or just want to keep up to date with general emergency medicine pearls and knowledge, check out EM Rapid Bombs. You can find that by going to our website, EM Board Bombs, or by looking at the link in this episode. Enjoy.
Let's see, what do we have
I think we're on number 4. We got 2 left.
All right. Yeah, so this has been recently my mission. Now, I'm going to start off by saying, like, with COVID, we are like so done with masks and so done with head coverings and all that stuff. And I get it. Like, we were restrained. But after COVID ended, when I go into rooms where central lines are being done, I see people with the gowns. I see people with the sterile gloves, but oftentimes I don't see any caps and I don't see any masks. And if you're the operator and you're putting in a line, even though you're doing it sterilely, as far as I'm concerned, that is not a sterile line anymore. That line's coming out as soon as they get up to the ICU. But in addition to that, the things I don't sometimes get to see when their lines are putting it is the nurses or the techs coming in the room. They come in the room where they're like looking over. It's like, hey, what you doing, doc? As like the spitool like is going into the sterile field. Anyone who comes into a room when a sterile procedure is being done needs to at the minimum have a cap and a mask on. That's sterile procedure. Like, that's sterile protocol up in the ICU. And again, if I come down and I see a line being put in, I'm not going to make necessarily like the line's getting stitched in as like, stop what you're doing or whatever. But that line's coming out as soon as they get upstairs. That is not a sterile line, despite the fact that you put so much effort in. So you spent so much effort doing the sterile prep. You did the scrub.
Just set up.
You did the cap. You did everything. Yeah. Just get everyone that comes in the room, monitor your area, and make sure that they come in the room with a cap and a mask at the minimum.
Totally. Now, what would you be the difference? You know, I'm sure a lot of people are listening like, what about a crash line? And I feel like there is such a thing as a crash line for sure, but there's also a thing as what I'm doing air quotes here if you can't see us on video, a crash line, which is I've had time to think about this and walk through it, but it's still a really sick patient. What would be your difference in what truly means crash, which is like you got to put a line in as soon as possible versus a sterile line?
To me, if you're like putting a sterile probe on your ultrasound and you put a drape down, it's no longer a crash line.
Of course, yes.
You spent the time, and so if you haven't done those extra little things, I'm going to say this, and I might get a lot of hate, but then you're just lazy. You just haven't done the little things because you did the big work. You just didn't do the small work. Now, a crash line has its place, and I'm fully behind people that are so sick you need to get a line in, and then you just do what you have to do. If you can do a chlor prep on the field, great. I mean, do something on the field just to clean it up while you're getting set up. Get sterile gloves on, and then after that, I get it. You know, you got to get the line in the person. But something that I still feel is underutilized in 2025, almost 2026, is an IO, intraosseous line.
Yeah, totally.
I still feel like they're like, I don't know, I still have to get that femoral line in crash, or I want to try to get the subclavian line in. It's like, you're sleeping on the IOs. You can put anything you want.
That's awesome. That's a quote right there from this pod.
There you go. But you could put anything you want through an IO. I still haven't found anything. You could rapidly infuse blood. And then like, well, we need 2 lines for pressors. Well, the person has 2 tibias or two humeral,
2 shoulders, 2 humeri, if you will.
I think that would be humeri, if you had them.
Yeah.
So you have 4 ports that you can put in to do interosseous lines. I put anything you want in there. And I'm not saying they won't need a central line, but if you're in an emergency department where things are falling apart and you need to get moving, don't spend time with the central line, especially codes is notoriously the one I see this happening in. Just get the IOs in.
Yeah. Don't mess with the central line.
Yeah. And if life smiles upon you and you have some time later on and I really want to do the triple lumen, then do it. Sterilely, of course, at that
Totally.
point. But then you could do it then. But again, we're talking about saving someone's life. We're talking about the barrier between the intervention and what you're doing should be seconds, not minutes. And so to
Absolutely.
me, IO is the way to go.
Totally. Yeah, it's funny because IOs, to me, I feel like the further you get away from the hospital into the field, IOs are much more utilized. But the further you go into the hospital, like even inpatient, I feel like, inpatient codes, things like that, people don't think about the potential for IO. And I remember even early in my career educating collaboratively, working with one of the trauma attendings at a shop I was at, and they were completely just didn't think about the potential for putting an eye. They do those crash um, cortices or crash vas cath, they put in or something. And here I'm saying, we have an IO drill right here. We can just do that. And that it's funny how that retooling, but in the pre-hospital world, this is second nature. I mean, that is what you go for because you don't have those central line kits and other abilities. So totally, I completely agree with you. And I'm guilty of it too. Sometimes I don't think about the obvious drill right in the room, resuscitate with me. But totally.
Yeah, it's part of our kind of heads up when we know the cardiac arrest is coming. I like
Yes.
2 IO kits in the room so that we're ready to go. And if we need access, that's the first thing we're doing. I do it on the floors. When I go to medical codes on the floors, I'm like, where's the IO? We're getting in the habit of doing it. Because again, it's not about the sexiness of what you're doing. It's really about getting that line in so that you can move on to the next task for that patient.
I want to say there's almost this like weird myth as well that we don't have to go into the deep dive in this, but people think, oh, it's a central line, it must be better. And in reality, that's obviously, you and I both know, not the case. The flow rate is even better on an IO compared to a central line. But it's fascinating because I think that's part of the thing. Sometimes when someone says we can put an IO in, and people are like, well, they always think that it's just not as effective. It's literally probably 100 times faster than putting in a central line of any type.
A standard, like a 20 gauge, like lumen that's in the triple lumen. People don't. Anyone should really look at the central line kit before they put the next triple lumen kit and just see the gauges. You get 18. You could get an 18 in there, but it's 20s otherwise. And it's just they're underappreciating it. And IO is a central line. I mean, I say it's a central. So I use that language so that the nurses can observe and that they could nudge the next group of doctors, because it's really nurses that insight change. And I just say, they're like, well, it's an IO. It's like, no, it's a central line. We're just putting in the bone.
Oh, that's
like,
good.
Okay.
That's deep right there. Food for thought. Cool. I think we're last point here. Point number 5. What you got?
Oh, this one is like almost so silly, but it's such low-hanging fruit.
This is a bunny,
what if I told you what if you could decrease your rates of hospital-associated pneumonias or ventilator-associated pneumonias for free? Like I told you that you could decrease the incidence of it just with one simple maneuver.
Sign me up.
Yeah, right? You don't even need a pharma commercial for that. Head of the bed elevated is such a simple thing. I come in to see consults sometimes after patients have been intubated and the x-ray comes in and the dust has settled and the patient's just laying supine. There's a variety of reasons why you'd want to keep the head of the bed elevated, like better diaphragm performance, less atelectasis, less derecruitment, better oxygenation, especially in obese patients. But the simplest thing is that by increasing the head of the bed 30 degrees, you're decreasing the rate of microaspirations that are happening and decreasing that person's risk of getting hospital-associated pneumonia, which is something we see on the floor of patients who have come in for another reason. Well, they secondarily have a pneumonia afterwards. So it's simple, it's cheap, it's free. You can say that you're helping the patient's oxygenation and ventilation out too, but it's one of those things that I want when I come downstairs. It's like almost one of the first moves I do is I'm saying hello to the patient or their family. I'm just lifting the head of the bed up.
That's awesome. How far are you on, like 20 degrees, or what's the number you're looking for?
30 degrees. You don't want to like sit them bolt upright where they're falling over into their lap, but like 30 degrees is more than enough. That's certainly what we do upstairs in the ICU.
Cool. That's awesome. I like how we're ending with the easiest thing you could possibly do. It makes sense.
Yeah, hopefully those are all pretty easy and straightforward. Again, I don't want to you told me not to talk about doing a transesophageal echo on patients.
Yeah, I know you just kept hamming that up on the podcast. Like, listen, we don't have time for that. This is not a highbrow podcast.
We're going to Impella in patients.
Talking about swan gans, floating the gans.
We're going to LVAD. Yeah, we're going to do an LVAD on the patient right there in the ED.
Steps to make a bedside LVAD.
You
one.
made me better today.
Let me recap these. So point number, let's see if I remember all these. I'm literally going off the cuff here. I don't have anything written down. So point number 1, you mentioned vasopressors as early as possible, especially after 30 cc's per kg. You should be doing them earlier if they're hypotensive. Just launch them. Norepinephrine is your go-to. If you're going downstream from that, we've talked about this before on this podcast. Our listeners know vasopressin and then stress dose steroids too. Point number 2, talking about analgesia before just doing sedation. So sedation's great, of course, propofol's fine, but adding in those fentanyl pushes and or drip, depending on your staffing models and your ED. And then we talked about Dex, also known as Precedex.
Say it.
I can't do it.
Say it. Dex. Say it with me.
Dex.
Met.
Yeah, sound that out. Dex.
You're gonna follow me.
Okay.
Dex.
Dex.
Met. Etomidine.
Dexmedetomidine.
Dexmedetomidine.
Great. So dexmedetomidine.
There
Brand
you
name
go.
Precedex. There we go. Yeah, was that good?
That's
Dexmedetomidine.
great.
I know. We'll have to have Vilt fun on practice with him. Dexmedetomidine for patients, especially as a calming agent, a light sedative, as they call it, that it does not take the place of treating alcohol withdrawal. And this is a great additive for patients that need something lighter, but it doesn't decrease the respiratory rate at all. The sprinkle, it's a seasoning. There we go. Get the seasoning fashion there. And then we talk about sterile central lines. Really, the only time you're doing a crash line is pulseless patient and or literally at that moment they need a line. And assuming you don't have an IO drill. Otherwise, you should be doing an IO drill. And then sterile procedure, full sterility, if you will, at all times when you're putting these central lines in. And the last point was the easiest, elevating the head of bed, 20 to 30 degrees, decreasing the rate of ventilator-associated pneumonia. That is awesome stuff in the ED we can do to help out our colleagues upstairs. How was that? I did well?
That was great. I mean, if we could do these little things, I think our patients be a lot better, and you'll impress every intensivist in the house.
That's all I aim for.
Yeah, right.
No, I'm joking.
Me too. When I work in the ED, I try to impress my colleagues.
Yeah, exactly. Yeah. No, a good collegial relationship is so important, and everyone knows how it is. Working upstairs and downstairs, it is a difficult job. So whatever we can do to help each other out is so important. So, hey, thanks for coming on. We got to have you on in the future. And it was great.
Oh, I'd love to.
It was great having you on here. We enjoy following you on Insta and the other socials. And thanks for contributing so much.
I appreciate that. We'll see you soon.
Yeah. And check out EM Rapid Bombs. You know where we are, emboardbombs.com. Where can they find you?
You can find me right here on Insta. And then we have our little conference that we run called Resussex every year. Our next one dates just announced, May 18th to May 20th in Philadelphia. If you love resuscitation and you like listening to Amal Matu and Anne Swaminathan, Sarah Craig, all the bigs, they're all there at the conference. So find me there.
I've been watching clips from it from last year, and they come up my newsfeed, and I also go looking for them, and they're really good. It's high quality stuff. So it's anything you'd get and or better at the major conferences that I've been to for sure. So check it out.
Thanks. I appreciate that.